Hello everyone, welcome to today's live broadcast, PTH testing in patients with chronic disease, kidney disease. I'm Robert Castellanos of LabRoots, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots and sponsored by DiaSorin. DiaSorin Incorporated offers the broadest, fully automated infectious disease and specialty diagnostics menu, including the best-in-class vitamin D. These quality assays are analyzed on the versatile Liaison Excel platform. They provide value through sales, service, and support solutions to clinical laboratories by consolidating their menu in order to streamline processes and increase efficiency. For more information, please visit diasorin.com. We have a few important announcements before we begin. This webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you have any technical problems viewing or hearing this presentation, please click on the support button at the top right of your presentation window or submit your problem through the green Q&A button lower left. This is an educational webinar and thus offers free continuing educational credits. After the webinar is over, please click on the CE button located in the bottom left-hand corner of your webpage and follow the process of obtaining your credits. I would now like to introduce you to today's speaker, Dr. Kevin Martin. Dr. Kevin Martin is Director of the Division of Nephrology at St. Louis University and Professor of Internal Medicine. He has served as a chairman of the General Medicine B Study section of the National Institute. Dr. Martin's clinical research interests include parathyroid hormone, vitamin D metabolism, and secondary hyperthyroidism. He has authored 230 publications in the professional journals, including the New England Journal of Medicine, Kidney International, the American Journal of Kidney Disease, and Clinical Journal of the American Society of Nephrology. I will now turn it over to Dr. Martin for his presentation.
Hello everybody, and thank you for joining this webinar today, where we're going to talk about PTH testing in patients with chronic kidney disease. I'm going to start by outlining how mineral metabolism is controlled in normal state, and then tell a little bit about the disturbances that occur in the presence of kidney disease and emphasize the importance of PTH, and to then talk in detail about how we measure PTH and some of the issues involved there that need perhaps to improve. So let's begin with a quick overview of normal physiology, where a complex system is in place to maintain the concentrations of calcium in blood in the normal and tight normal range. This system, although it looks complex and perhaps is, but it's very effective, and the integrated actions of all these factors can keep the level of ionized calcium in a very narrow range, maybe with a range of less than 10% for an entire lifetime. So what the slide depicts is, in response to a fall in the levels of ionized calcium, the parathyroid glands are stimulated to secrete PTH. And then PTH does several things. It acts upon the bone to mobilize calcium and phosphorus. It acts upon the kidney to increase the reabsorption of calcium. And it also acts upon the kidney to increase the production of 1,25-dihydroxyvitamin D, which is the active form. And it too then will act upon the intestine, where it will also increase the absorption of calcium. So all of these effects then are designed to restore a fall in the level of serum calcium back to normal. But you'll notice that when PTH resorbs calcium from bone, it also brings with it some phosphorus, which is undesirable in this situation because it would tend to offset the correction in calcium. And at the same time, when 125 vitamin D acts upon the intestine, it too results not only in the absorption of calcium, but also in the absorption of phosphate. Again, the rise in phosphate absorption is an undesirable consequence. So these undesirable consequences of simultaneously mobilizing phosphate are handled in two ways. One of the actions of PTH upon the kidney is to increase phosphate excretion, and so that would tend to offset this rise in phosphorus in blood. And in addition, there's a separate hormone, FGF23, which not only will have its own actions on the parathyroid, but also is an important hormone for increasing phosphate excretion by the kidney. So the integrated result of all of these actions is, triggered by a fall in ionized calcium, is that the parathyroid hormone, vitamin D, FGF23 systems all work together to correct the abnormality and restore the ionized calcium back to normal. And as I said, it works extremely efficiently. And that's because the effect of calcium on PTH release is controlled very tightly. And here's a study showing the effect of extracellular calcium on the release of parathyroid hormone from isolated parathyroid cells. And you can see it's a very steep curve in the mid portion here, and it's set really with its midpoint about where the level of extracellular calcium concentrations need to be in blood. So this is important because it can respond very quickly up or down in response to various stimuli and begin an immediate effect to restore the abnormalities back to normal. So let's move then to talk about what happens in kidney disease. And let me point out that disturbances in calcium, phosphorus, parathyroid hormone, and vitamin D metabolism have been traditionally recognized and treated for their role in causing renal bone disease, or by the words renal osteodystrophy. So this has changed a little bit in recent years because it is now recognized that the consequences of these abnormalities on mineral metabolism extend beyond the skeleton, and in fact have been implicated as important factors in cardiovascular disease and contribute importantly to mortality in these patients with chronic kidney disease. So actually what happens now is the new term was introduced, CKD-MBD, standing for chronic kidney disease, mineral and bone disorder. But what it actually is a combination of abnormalities, not only here in bone, but also giving rise to a number of biochemical abnormalities, which we'll discuss. These can contribute to vascular calcification, which is an important contributor to cardiovascular disease and mortality. And of course, these all overlap to greater or lesser extent and contribute substantially to morbidity and mortality in patients with chronic kidney disease, making it important for us to try to detect and then begin treatment for these issues. So in the last several years, chronic kidney disease has been divided into several stages, and by changes really in the level of GFR. So you can have a normal GFR, but in the presence of kidney disease, usually GFR is good, but there's other manifestations of this. And this is the early stages where we need to assess for complications and begin to treat them to try to minimize any of these other effects that I've mentioned, whether it be on bone or cardiovascular system or the other mineral abnormalities. As kidney disease gets worse, then it can progress to various stages where we have to begin a clinical attack on minimizing collateral damage and the effects on bone and the heart. And these efforts need to intensify as GFR falls further, so that we can minimize these abnormalities taking place when kidney disease progresses to an advanced stage, or maybe even when dialysis is required to provide some support in the absence of sufficient kidney function to keep the patient alive. So just to illustrate when these problems occur, this is a slide from one of the recent papers from Drs. Isakova and others, just showing really that PTH levels begin to rise very early in the course of chronic kidney disease and rise well above the normal range by the time, certainly by the time kidney disease reaches stage 3. Now, it's not the only abnormality that occurs earlier, but there's a number of abnormalities, both in calcium metabolism and vitamin D and phosphorus, as well as intrinsic abnormalities in the parathyroid glands that contribute to all of these consequences. And the last one on the slide, which I won't really address, is there's an abnormal response of the skeleton to PTH in the presence of kidney disease, meaning that you usually have to have higher levels of PTH than normal to try to maintain bone turnover in the normal range. So here's an example of what happens with the levels of active vitamin D in the course of kidney disease. And you can see on this slide that the levels of 125 vitamin D begin to fall here, the orange bar, when kidney disease is mild, and progressively fall as kidney disease gets worse, going from left to right on the slide. And you can see also in the blue line that PTH levels begin to increase throughout the course of chronic kidney disease and rise certainly above the normal range by the midpoint here. And this can vary substantially by the type of kidney disease and a variety of other factors. But nonetheless, suffice it to say at this time that these abnormalities in bone and mineral metabolism begin to occur early in the course of chronic kidney disease and progress throughout if treatment is not undertaken. So probably what happens is illustrated in this slide, where because of this disturbed bone and mineral metabolism, several of these hormones become abnormal early in the course of kidney disease. And this slide depicts what might happen not only to PTH, shown here in green, but this may be even preceded by changes in the other hormone I mentioned, FGF23, or indeed by a progressive fall in Klotho, which is intimately involved in FGF23 metabolism. And all of these clearly start early and can get progressively worse as kidney disease progresses. So with that brief background of the abnormalities and the timing of events, I want to turn the focus to PTH, which is certainly a major player in mediating all of these complex interactions and causing the complications of the skeleton, in the heart, in the blood vessels, and a variety of other tissues. So here's a diagram of PTH. It's an 84 amino acid peptide. And its biological actions are to increase calcium in blood and to decrease phosphate in blood, as I mentioned earlier, when you have normal kidney function. It's absolutely important in terms of structure function studies to have the first few amino acids in place here. Certainly the first 2 or 3 are critically important for any biologic activity. But most of the biologic activity, if not all of the biologic activity of PTH, is contained within these first perhaps 34 amino acids of PTH, so the N-terminal 1 to 34 PTH, which can mediate, as I said, most if not all of the biological actions of PTH. So the idea that we're going to discuss in more detail now is how to measure PTH in blood. And on this slide, it shows how PTH assays have evolved over the years. The first PTH assay was introduced in the 60s using the radioimmunoassay technique by Dr. Yallo. And you can see that the first antibodies that were raised here against PTH were directed, see if I get my pointer on again here, were directed towards the C-terminal region of the PTH molecule, shown by this blue bar here. So these assays were useful and sort of opened the field to some of the parathyroid hormone physiology, but the assays were extremely variable and became really problematic in the course of chronic kidney disease, as I'll show you in a minute. Probably a decade later, another assay was introduced with its recognition site somewhere in the middle of the molecule, the so-called mid-region molecules that became popular. And this performed a little bit better clinically, but again was subject to a lot of variability and particularly problematic in the presence of kidney disease. Now, as I've mentioned, all of the biologic activity is contained within the first 34 amino acids. So why wouldn't it make sense to try to direct an antibody against this region, and maybe that should perform clinically better? So such assays were introduced and unfortunately really didn't perform better. Mostly, I think now, looking back, is for reasons of sensitivity, etc. So the big breakthrough in PTH assay then came with the first generation immunometric assays using a 2 antibody technique, where the PTH could be captured from blood by an antibody directed towards the C-terminus, for example, and then detected with a second antibody directed towards the N-terminus. So this technique was introduced and gave rise to this whole series of what were called intact PTH assays that are currently in widespread use. And in fact, if you order PTH from almost any clinical site these days, you will get one of these various assays, which we'll talk about more in a minute, labeled as intact PTH. And finally, a refinement in this was introduced later, which we'll also talk about, where the detection antibody was moved right to the very N-terminus of the PTH molecule, and so really should only measure PTH 1 to 84, the full-length molecule, and perhaps a way to exclude some PTH fragments that really are the root of the problems with all this PTH assay. So here's an example of what happens within the parathyroid cell. PTH is made as a full-length 1 to 84 peptide and stored in secretory granules pending a stimulus for secretion. If there's a fall in levels of ionized calcium in blood, it signals at the calcium sensing receptor at the parathyroid membrane and causes the granules to fuse with the plasma membrane and enter blood. If calcium levels are high rather than low, then through signaling at the calcium receptor, PTH that's manufactured in the parathyroid cell can undergo degradation within the gland, and even to various fragments here, perhaps smaller molecular weight fragments with truncated N-terminus, as shown here, perhaps larger fragments of PTH really missing the entire amino terminal, 34 amino acids or so, or perhaps even N-terminal peptides themselves. And these indeed can be secreted also and appear in the blood. So you can begin to see a complex picture here of how many problems might arise with PTH assay when you're trying to pick the 1 to 84 molecule from the blood, because in the circulation, in a simplified form, we really have a family of PTH peptides, not only the PTH 1 to 84, the full-length peptide, but also N-terminally truncated molecules, some larger C-terminal fragments, some smaller C-terminal fragments, and probably very little, if any, of a biologically active N-terminal fragment. But you can see the issue here is how do you begin to pick these the intact peptide or the peptide of interest out of this complex mixture of PTH peptides in serum. But it becomes even more complex, and I thought it's nicely illustrated by this old experiment from Dr. Mayer many years ago, where he successfully was able to cannulate the venous effluent of parathyroid glands of live animals. And when he fractionated this by gel filtration, so separating things by molecular size, he was able to demonstrate that what came out of the gland was a mixture of the intact hormone here at the arrow, and also smaller molecular weight PTH fragments. And interestingly enough, as you can see both to the left and to the right of this, this varies according to the state of calcium in blood. If serum calcium is low, so hypocalcemia, most of what comes out of the gland is the intact PTH, whereas if the calcium is high in blood, some PTH still comes out, but it's not the biologically active 1 to 84, which should come here. It's a smaller molecular weight fragment of PTH that has no biologic activity. So the important point here is the proportion of PTH and PTH fragments that come from the gland can be varied according to the level of serum calcium. And it kind of makes sense in a way, because we've said that PTH is responsible for the minute-to-minute control of serum calcium. It takes about 20 minutes to manufacture PTH from an initial signal in the gland. So what actually happens is that PTH is being made all the time, but being degraded within the gland if it's not required. And so it builds up this pool of fragments within the parathyroid gland that I mentioned earlier. But if serum calcium goes low, the degradation can immediately reduce in a very rapid acting effect, and so making active PTH rapidly available to correct a fall in the levels of ionized calcium. So it makes physiologic sense that you'd have a mechanism for rapid release of PTH and rapidly making PTH available if indeed there's a stimulus. But this calcium effect on the fragments that I mentioned means that the ratio between active PTH and PTH fragments can vary according to the level of calcium in blood, complicating the measurement and interpretation of PTH. And just to make matters infinitely more complicated, these PTH fragments can also appear from metabolism of the active hormone in peripheral tissues. And shown here, you can see that if you inject purified PTH 1 to 84 into an animal and then sample what's in blood, as time goes on, you can see that PTH 1 to 84 begins to disappear and fragments begin to appear. So that these fragments can occur not only from secretion in the parathyroid gland, but also from metabolism in peripheral tissues. So what does this mean then in terms of what we might encounter in clinical medicine? So first let's look at a normal situation shown in this pie chart here. You can see that here in a normal person, there's the orange slice of pie is the active PTH. There's a small amount of PTH inactive fragment, so-called PTH 7 to 84, as I'll show you in a minute, is actually a family of peptides. But the vast majority of the circulating PTH peptides are shown by the blue part of the pie, which are inactive, smaller molecular weight PTH fragments. In the setting of chronic kidney disease, you can see there's marked increases in the levels of PTH. there's a tremendous increase in the PTH fragments shown in blue because they depend on the kidney for excretion from the body. And there's approximately equal amounts of intact PTH and the slice of the pie in yellow showing the 7 to 84 family of peptides. So in actual fact, as I mentioned, there's a whole family of PTH peptides here with varying truncations from the N-terminus on, making it very complicated to try to measure PTH unless you have extreme specificity of your assay. And so if you look at this slide and take the various commercial assays that are available at the present time and look at a single patient sample, you can see the result that can be obtained here can go from a value of 54 in this assay to a value of 183 in this assay. So from a clinical perspective then, you need to know what's correct. Is the PTH 50 or is it 180? And how can it vary so much across the various PTH assays? And it turns out that the reason for there are several reasons for this discrepancy, but a major one is commercial PTH assays react differently to this PTH 7 to 84 family of peptides. Some recognizing it extremely well, some recognizing it extremely poorly. And so with this kind of variation in what's being measured in the plasma, it's not surprising that there's tremendous variation across all of these commercial assays that are in use. So to hammer home this point a little bit more, this is a simplified diagram of what can happen in a patient with advanced kidney failure. And if you measure PTH in one of these commercial PTH assays and get a value of 500, this could represent equal parts, for example, of intact PTH or the PTH 7 to 84 family, which as a reminder does not have biologic activity. Or the value of 500 could represent only 100 picograms of active PTH and 400 picograms of inactive PTH fragments. Or it could mean that there's 400 picograms of active PTH and very little 7 to 84 family of peptides. Yet in an intact assay, depending on the particular assay in use, you would get a value of 500. And you can see then that this is really the issue. It's a problem of interpretation. It's a problem of biological correlation, and makes the proper interpretation of assays very difficult indeed. And there are clinical examples where this situation absolutely occurs and can be easily demonstrated. So for the even more recent and more comprehensive data looking at the recognition of PTH 7 to 84 family of peptides of various assays, you can see that it varies quite considerably among all of the commercial PTH assays that are available. So it is possible, and I alluded to this briefly, it is possible to exclude all of these 7 to 84 family of peptides from PTH assays, such as the intact PTH assays that I've been mentioning. So here is one such assay, or diagram of it, showing what is being measured by HPLC. You can see that in this sample there's a lot of PTH 1 to 84 and quite a bit of PTH 7 to 84 family over here. But if you move the detection antibody for PTH to the very N-terminus of the molecule, then on HPLC all that is being measured is the intact 1 to 84 peptide. So there are such assays have been generated and are in clinical use, and we'll talk a little bit more about those in detail, because it eliminates a lot of the complications that arise from the non-specificity of the intact PTH assays and the varying reactivity to all of this 7 to 84 family of peptides. So you can see with this being the case of PTH assay at the moment, when this KDIGO group met to try to make clinical practice guidelines, you can already begin to see the extent of the difficulties that might be involved here, and to try to suggest what are reasonable levels of PTH to try to associate with good outcomes in patients with kidney disease. So there were really two stabs at this over the past 10 or 15 years. The first one was from a group, goes by the acronym of KDOQI, and they suggested a good range for PTH in dialysis patients should be between 150 and 300 to make guidelines for where your serum calcium should be and your phosphorus should be. And in general, these were accepted and thought to be reasonable clinical goals to be associated with good outcomes. So the problem here that the assays used to generate these kind of numbers is no longer in existence, and have given way to the variety of intact PTH assays that I've mentioned in the past few slides. So later on then, these guidelines were refined by KDIGO group, and they tried to address this issue of variation in PTH assay and tried to suggest that this might be improved then in terms of targets by using a multiple of the upper limit of normal, and suggested a good PTH range might be between 2 times and 9 times the upper limit of normal for all of these assays that might exist, and in this way try to achieve some homogeneity in recommendations for plasma, allowing for the variable results obtained by the different commercial assays that are in use. And to a large degree, this is at least partially successful, but we still have a variety of epidemiologic evidence that tends to keep the best range here in this range of PTH values. So somewhere in assays that are close to the original one to do, it's still probably a reasonable range to try to shoot for, but allows values to run a little bit higher if indeed the assay in use detects this 7 to 84 family a little bit better. But the issue is still problematic, because I'm not going to go into the details of this here, but these boxes are trying to classify patients, whether you're in range or out of range, according to these KDIGO practice guidelines. And using different assays and this kind of numbers, you can see that the results are still quite variable. So here you get a lot of dots in the white box here. Here you get much fewer with this assay, and here you get somewhere in between. So it's not ideal by any means for trying to achieve homogeneity or validation of these practice recommendations. So to summarize this part, let me just say that the target PTH range for dialysis patients recommended in the original KDOQI practice guidelines of 153 to 300 was based upon correlations with bone biopsy, and correlated well using this intact PTH assay. But this assay is not available any longer, so that was meant the need for to accommodate a different range of PTH, and also the more recent data was able to find better correlations with some cardiovascular issues, and already suggesting that broadening of the range might be beneficial. And so these was the information that caused the KDIGO group to try and change their target range. But the big question remains, as shown here, is what about all these PTH assays, and do they really correlate, and should the targets be valid, and how could this problem be solved? Should we try to standardize PTH assays? And we'll talk a little bit more about that in a minute. Should we apply correction factors to the various assays that exist so that they could use targets, appropriate targets, or should we just use targets that are specific to a given assay? And so that's where the KDIGO group came in this recommendation at the bottom here. So it says that we should try and keep it between 2 and 9 times the upper limits of normal for these particular assays, and maybe that would begin to cause some coalescence and corrections for the various PTH assays be used. So there's another problem with this, though, is how good is your reference range if you're multiplying by an upper limit of normal. And so yeah, you should really be sure who your normals are, and this was approached by Cavalier and others, who really tried to be sure that the normal values were indeed normal and take into account the chemistries in those that you consider normal, not just people that were convenient in the lab, for example, but make sure they didn't have changes in serum calcium, that their kidney disease was really normal, that they weren't taking medicines that could interfere with the control of bone and mineral metabolism, that they didn't have kidney stones, and most important, that they weren't deficient or insufficient in terms of vitamin D. And so they took on to try to screen normals for this, and found that if you were careful with the normal subjects to set a normal range, that you did indeed find differences in the values that could be significant. For example, if you look here in this assay, in this assay up here, the Alexis assay, the upper limit of normal is 65 by the manufacturer. But if you make sure your normals are indeed normal, then the upper limit of normal is only 50. So then it makes a difference if you're multiplying 50 by 9 or 65 by 9 as an upper limit of normal. You'll see that you're going to get quite a bit of difference. Similarly, in this assay down here, if you multiply 36 by 9 or 54 by 9, you get quite a spread in the range. And again, with this assay here of 50 or almost 90. So the upper limit of normal is, if it's loosely defined, is not very satisfying in terms of trying to homogenize the PTH assays. And the difference that can make here is if we took a value of any of these ranges here in this assay, you would have a range here of, say, 170 to almost 800. But if you controlled your normals, it's between, say, 100 and 400. So you can begin to get a flavor of the difference this makes, and how unsatisfactory it is to specify multiples of the upper limits of normals if you don't really rigorously define the normal population from which the normal range was defined. So clearly we have a ways to go in trying to get some agreement and homogeneity in how to define these results. So one part of the practice guidelines said, when suggested at least, that when you report lab tests for patients with CKD, we the KDIGO group, the practice guidelines group recommend that clinical laboratories actually say which method is in use and report any changes in methods, or if they change their sample source or handling specifications, so that you can facilitate the appropriate interpretation of biological data. And so this is important. And maybe what we'd like to see in the field is if the lab reports a PTH value, just say what assay is used. In our own hospital, for example, the hospital lab changed from one PTH assay to another and didn't inform the clinicians. So all of a sudden we began seeing values for PTH that were almost twice what we thought they should be in these patients. And on inquiry then, the lab said, oh, yes, we changed our PTH kit. The normal range didn't differ that much, but they didn't rigorously look at patients with advanced kidney disease, where all of this problem arises because of the differential detection of these PTH fragments. So it would be really nice if we could get clinical labs to agree that they would just inform the lab of the particular assay used, and until we could get some handle on how to refine this and approach the issue of PTH standardization. So in conclusion, I'll just wind up with a few comments here. We do need to measure PTH in all stages of chronic kidney disease because it's an important cause of morbidity and mortality. It is a target for correction, and we know if we can direct treatments at controlling it, we can achieve improvements not only in the skeleton, but in other target organs for PTH. We believe that in this disease state of chronic kidney disease, we need, and the clinicians need to be aware, as well as the laboratory people, of some of the current pitfalls with PTH assays, that the methods are variable, reference values even are not defined. There are differences between assays and even samples and stability and storage and shipping, etc. And so we have to be vigilant that we try to keep this as tight as possible. There are other bone markers that we can use to complement PTH measurements, but they're not at a stage where they by any means would replace PTH. There are also new hormones that are emerging. I mentioned a little bit about FGF23. There are other markers like for bone metabolism that are beginning to come into under clinical scrutiny for use here, but are not available in the current panels of assay that are used to try and assess these abnormalities in bone and mineral metabolism and chronic kidney disease. And a lot more work needs to be done before these can be incorporated into routine clinical practice. So it is necessary, I think, to continue to work hard and push hard trying to achieve standardization in PTH assays and to have some knowledge of the particular specificities and whether it's other assays that don't measure these PTH fragments will actually ultimately be the way to measure PTH, and a lot more work and data is required before that might make this whole area a little more reproducible. So with that overview of some of the issues and problems in kidney disease and the measurement of PTH, I'm going to stop at this point in time, and I'd be happy to take and try and address any questions anyone might have and see if we can clarify any issues further. So thank you very much to everybody for your attention, and as I said, I'll be happy to take any questions and return this control back to the studio. Thank you very much.
Well, thank you very much, Dr. Martin, for your informative overview and presentation today. Before we transition in today's Q&A, I would like to remind the audience on how to submit questions. You can submit your questions by typing them in the Q&A box, and that is that green Q&A button at the lower left of the presentation window. We're going to try to answer as many questions as we possibly can during this time. So Dr. Martin, our first question that we have, do vitamin D supplements have any effect on CKD?
I can address the first question here by first reading it to you. It's asked, how close do you think you are from refining this test? Well, I think we're getting closer. I think we have a lot of interest, and we've defined the problem, defined the variable cross-reactivity and measurement of these fragments. It is possible to eliminate them from the assay. We have worked to develop a mass spectrometric assay and are trying to correlate this with the two-site immunoassays. So hopefully we can get it soon. There's an international group that meets regularly trying to address the issue, and I imagine over the next maybe optimistically year or two we'll be able to refine this further. So I'll turn you back to so we can move to.
Thank you, Dr. Martin. Our next question is, how clear is that PTH fragments come from the post-transitional modifications rather than the regulation events on the RNA, such as alternative splicing, for example?
So it's possible all are here. Most of the fragments arise from intraglandular and peripheral metabolism. But there are some post-translational modifications of PTH that also occur, and I glossed over these on the slides I have. They occur in about 1% of the samples, and it's a problem with only particular assays. If the detection assay is directed at this region where a post-translational modification has occurred, then it doesn't detect the PTH, and although it is biologically active, you're just not able to measure it. So these samples do exist. The way to eliminate them is to don't use an assay that would have a detection antibody in this area, such as a 1-84 PTH assay. But I think we need to learn more about it and just be aware that it can be there. And if one thought there was severe hyperparathyroidism, but the PTH values you're getting are not consistent with that, maybe it's worthwhile to consider using an assay that just measures PTH 1-84 and no fragments at all. It's a good question, though. Thank you. So I'll turn you back to that.
Thank you very much. So this next question that we have is, sunlight enhances skin vitamin D production, and vitamin D is part of the California regulatory stuff. What's the ultimate effect of sunlight on PTH testing and chronic disease, kidney disease?
Sunlight, of course, is important for vitamin D metabolism. This is what makes us make vitamin D precursors in the skin and contribute to our vitamin D in serum. So sunlight contributes, and we get some also from our diet. To have an adequate production of vitamin D from sunlight, you need to have at least maybe 15 minutes twice a week, arms and legs exposed to the sun, and longer than that in the northern hemisphere. So in general, it needs some supplementation, particularly in the setting of chronic kidney disease, where vitamin D, 25-hydroxyvitamin D, indicating our overall vitamin D status, tends to be low. So if there is some PTH hyperparathyroidism in kidney disease, it's not unreasonable to correct any existing vitamin D deficiency first, but probably it's best done by oral supplements rather than rely on sunlight. Sunlight just isn't good enough for most of the people, at least in North America. Thank you.
Thank you. Why is there no standardization of PTH 184, and why are there no international recommendations for labs to use PTH 184?
I'm not sure what question was asked there, but if it's number 6, do vitamin D supplements have any effects on CKD? And the answer is yes. Correction of vitamin D deficiency will suppress levels of PTH and control hyperparathyroidism. Perhaps also have other effects on the kidney, such as reducing proteinuria. So part of the practice guidelines is to measure vitamin D status in the presence of chronic kidney disease, and then correct any levels as a first step in controlling hyperparathyroidism. I can move then to the next question, which asks, why is there no standardization for PTH 184 and no recommendation for labs to use PTH 184 assays? I think this is evolving. There's a moves, as I said, to try to get some international standardization. The World Health Organization has a standard. It's not necessarily the best standard, and it's not well incorporated into most lab testing at the moment. But there are regular meetings ongoing, and hopefully with a little more data as to the appropriate standards and have buy-in from various manufacturers of PTH assays, I am optimistic that we can get there, particularly as these PTH 184 assays become more available and eliminate the problem of the other 7 to 84 family of peptides that really cause a lot of the variation. Thank you. It's a good question. Return it to you, Bobby.
Thank you very much. In one of your slides, you mentioned a multiplication factor of 9. Why?
Yeah, the multiplication of a factor of 9 came from the KDIGO practice guidelines. So I think what they were trying to do here is to consider the range of PTH values that might be encountered using this spectrum of intact PTH assays that I mentioned to you. And they thought that there was a need to broaden the range somewhat from the original KDIGO recommendations. So they based it on using results from bone biopsy correlations, which actually use one of the PTH assays that gives high values, that measures these truncated fragments very well. But they thought that this would be a reasonable range to cover most of the assays in use. And really, in the absence of more definitive data, it's hard to argue too strongly with it, because the correlation of PTH values with parameters of bone histology is good, but not perfect. So I think they thought that a little mild overactivity was probably okay, and rather than trying to treat to a very narrow range and risk the idea of over-treatment and have bone turnover excessively low. So it's not an unreasonable range with the intact assays that are available today. I would add one final word, perhaps, is it's best if you know your assay. If you knew the assay you were using gives values on the high side, then I would use up to the factor of 9. If I knew that the values were on the lower side in this spectrum of assays that I showed you, my inclination, personally speaking, would be to move that down maybe to 4 or 5 times the upper limit of normal. But it's important really to know your assay, and then we could make reasonable stabs at which one to use. So thank you for the question. I turn it back to you, Bobby.
Thank you. Would monitoring PTH be critical in diagnosing and treating patients with calphylaxis?
Yes, calciphylaxis is a very serious development in patients with chronic kidney disease or patients on dialysis. There's really a broad spectrum of patients involved with this. Some patients would have severe hypoparathyroidism. Most of these would have what's called a peripheral calciphylaxis, and certainly monitoring PTH and dealing with a very high PTH would be critically important in their management. In many cases of calciphylaxis, PTH values are actually low, and perhaps a low value of PTH is contributing actually to the calciphylaxis. So in those, it can be helpful in directing your treatment. So if PTH values are very high, you would try and eliminate PTH as a risk factor for calciphylaxis, even going forward with parathyroidectomy or treating with calcimimetic agents, which can effectively suppress PTH levels. If the PTH values are low, and most of these will have this central calciphylaxis, or with necrosis on abdomen or thighs, etc., then the idea is to try to really use a multifactorial approach at treating, and there's no point in trying to suppress PTH further. So PTH values are a critical part of directing your management of calciphylaxis, and certainly are important to have available for that. Thank you for the question. I'll return back to you, Robert.
Thank you, Dr. Martin. And Dr. Martin, could you please elaborate on the effects of PTH in pregnancy? Also, in European nation or the European Union, they have different measurements of PTH.
Thank you. Yes, PTH can certainly change during the course of a pregnancy. A lot of it dependent on the pre-existing health and vitamin D health. The PTH levels can increase during pregnancy, and that certainly has been noted in some patients, mostly thought to the contribution of sending calcium values to the developing baby. The placenta can make 125 vitamin D, which can control PTH. So yes, PTH is part of the changes in mineral metabolism throughout pregnancy, which also involve changes in vitamin D. Yeah, in Europe, the situation is a little bit different. There are many in-house PTH assays used throughout Europe. They all have their own range, their own standards, their own types of characterization. Some of the commercial assays that are used in Europe are also used in this country. But the data that I showed you for heterogeneity of PTH assay is even more problematic in Europe because of the number of in-house PTH assays that are used and not available to everybody. So that's a real problem, and I think that's where some of these other questions that deal with efforts to try to achieve international standardization will be really important, and hopefully we can continue to work forward on that and get some standardization to this issue.
Hey, thank you very much, Dr. Martin. And I do have one final question here. Does the increase of PTH fragments in late stage affect the sensing membrane to decrease the amount of inactive PTH?
Yeah, so the PTH fragments that accumulate in the late stages of chronic kidney disease, we don't believe have any significant biologic activity. So I think in and of themselves, I don't think they do any harm. They just complicate the measurement, really. And the risk is that if you're measuring these fragments, which, as I said, are inactive, that you can overtreat hyperparathyroidism and facilitate the state of very low bone turnover, which has a lot of problems in and of itself. So it's mainly, I think, an assay issue and what we're measuring, and it misleads on the levels of PTH that you're achieving with your therapeutic efforts. So it is important. Thank you.
Thank you very much. So I just wanted to also just thank you again, Dr. Martin, for all your informative information for today. Do you have any final comments?
Thank you. I think the final comment is to try to spread the word that PTH assays are heterogeneous, and try to know which assay is being used. If you can influence it, try to have the labs say which PTH assay is being used, and on our end we'll try to continue to work towards trying to achieve standardization of PTH. So thank you. Thank you for all your questions and attention.
All right. Thank you again, Dr. Martin. I'd also like to thank our sponsor, DiaSorin, for making today's educational webcast possible. Today's webcast will be available for on-demand viewing through February 28th. You'll receive an email from LabRoots alerting you when this webcast will be available for replay. We invite you to forward that announcement to your colleagues who may have missed today's live events. And with that, we'll see you next time. Goodbye.